of you here. Just a minute. I hope I'm audible and visible to all of you. A very good evening to everyone who are preparing for the entrance exam. The exam is just around the corner. And as promised with all of you, I'm here. And the first thing I'm going to discuss with all of you is related to the topics that you must not miss before sitting in the NEET super specialty exam. The selection of the topics is based upon the previous year questions as well as the way questions are being asked in the NEET super specialty exams, as well as a few topics which were trending in INI super specialty exam as well. So let us start with the thing. First of all, have a look at these topics. So topics which are must for revision in the last week, I have highlighted them here. So just a minute, please. So these are the topics you have to go through before you sit in the exam. First of all, Nelson 22nd edition updates you cannot miss. Nelson 22nd edition. In the recent INI super specialty exam, about 4 to 5 questions, direct or indirect, were asked from the changes, the updates in Nelson 22nd edition. In the PrepLadder's SS app, there is a separate segment. Don't miss out if you are not confident about it. Second thing is ISPN guidelines on nephrotic syndrome, both SSNS and SRNS, including the monitoring. Special emphasis should be given on the aspects related to thromboembolism, how you're going to manage, what about vaccination, and what is the supportive therapy given in a SRNS patient. So please go through those review articles in full detail. Then Barter, Gittelman, Liddell versus Gordon syndrome, very important. Every alternate exam, there is a question on Barter syndrome versus Gittelman syndrome. There was a question in NEET PG 2019. There was a question in NEET PG 2022. 20 question, the more reason this time you can expect a question. Then Alport syndrome and its related DDs is another topic from where questions are frequently asked. Then topics like spinal muscular atrophy, congenital myopathy, muscular dystrophies, and neurocutaneous syndromes are frequently asked. Neurocutaneous syndrome is a very, very high yielding topic, often asked in your exams. Then syndromes which are included, some of the syndromes I have discussed with you yesterday live. Microdeletion syndromes, ranging from Dye-George syndrome to the rare syndromes, you all are supposed to do them. Then genomic imprinting topic, as well as related syndromes like Prader-Willi and Angelman, and the usual trisomies are important. Therapy of ADHD is very important. Direct, indirect, some question is always asked on this. Rett syndrome in detail, including the new drug which is available. Rickets variants, nutritional rickets you need to do, but the other forms of rickets, especially X-linked hypophosphatemic ricket, the VDDR1, VDDR2, Dent's disease, which can sometimes produce rickets like manifestation, you need to go through. A beta lipoproteinemia has been asked 3 times in various super specialty exams, NEET SS as well as INI SS in the last couple of years. Then hepatitis B and hepatitis C focus on the serological pattern, particularly that table of hepatitis B, and treatment in both anti-HBV drugs, anti-HCV drugs, frequently asked. Celiac disease, particularly the diagnostic pattern, and cystic fibrosis, not only the type of gene mutation as well as CFTR modulator, that is the hot topic, the CFTR potentiator and CFTR corrector, which is used where you need to remember thoroughly. GI foreign bodies is one of the favorites of NEET super specialty examiner. Wilson disease and Ehlers-Danlos syndrome. Ehlers-Danlos syndrome was asked 3 times. Again, in the last 2 years, it was asked in 2 NEET SS and 1 INI super specialty exam. Then we have drugs. Drugs are often asked. Antiarrhythmic drugs, there is a complete unit I have discussed. You need to go through that. Apart from that, all the cardiovascular drugs, you can expect at least 1 question to be asked. In addition, heparin is very important. Mechanism of action of heparin has been asked 2 times. It has been asked in 2018. It was repeated in 2022. Caffeine citrate has been asked, including the toxic levels as well as the therapeutic level. Remember the Cloherty value, which was the option given in one of the exams. Major monoclonal antibodies you need to go through. Don't focus on the T half of this or the dosing of this. Just remember, where does it act, what is the route of administration. Some are given as IV infusion, some are given subcutaneously, some are given as IV boluses also, some are given as weekly IV injections, and which one is used where. Then hydroxyurea is important. Hydroxyurea is useful in sickle cell anemia, thalassemia. It also has some side effects. And then anakinra is again, it's not a monoclonal antibody, but you will find it among the options given in the question. Then febrile seizure need to be revised once before the exam, including the tables of Nelson. Status epilepticus is important. Dravet, Otahara, Lennox-Gastaut, and Landau-Kleffner syndrome, LKS. I'm assuming that West syndrome, absence seizure, and juvenile myoclonic epilepsy, these topics you have already done. They are also important, but they are easier ones. These are the slightly tricky ones because we don't tend to read them that often. IMNCI guidelines on dehydration and pneumonia are important. Congenital lung malformations are very important. Among infections, scabies 2 times has been asked consecutively. Would hat trick be made this year? You will be telling me. Question asked in NEET SS 2022, question asked in NEET SS 2023. And both times options changed, but the question was Hamesha on the same way. The question was, which of the following is true? I was just able to get that question from one of the forums for discussion. It was in one of my own forum, which I had closed long back. So the question was in 2022, all of the following are true regarding scabies in a child, except four options were given. Rarely spread by fomites. Causative agents is Sarcoptes scabies, which is an arthropod. Option number C, nodular scabies seen in AIDS patient. And option number D, treatment is 1% permethrin cream applied overnight. These were the four options. And if you see carefully, you would know that the options are very close. Two of the options were repeated, two of the options were changed in the repeat question which was asked. So scabies question, scabies topic. Let's see if hat trick is made this time or not. Then molluscum contagiosum, a topic which is very common, but we tend to ignore how you are going to manage and what are the approved therapies in children compared to adult. Also, genital molluscum will not be seen in children. You will be finding the typical facial molluscum in the children. Then HIV, everything related to HIV is important, including new anti-HIV drugs, including you need to remember what is the age group in which uh, dolutegravir should be given, what is the age after which tenofovir can be used, and the infant feeding guidelines. The update I have posted in the pediatric super specialty app of PrepLadder. Then measles, rubella need to be done in details. Mumps, enteric fever, and rickettsial infections need to be done in details. I'm not saying questions will be asked. There is a possibility nothing is asked from them. There is a possibility a lot of questions are asked from them. But going by the pattern, you must go through them and be sure that you have seen them at least once, even if you spend only 5 minutes on each, so that you are, in a way, ready for the question. That confidence should be there when you see the question. Fetal assessment, very, very important. Fetal assessment generally asked in INISS, but if you see the NEET SS exam, there also questions are being asked. And read Cloherty on this. Cloherty say direct line they put up. If you have not read Cloherty yet, anyways, your preparation is faulty, but I'm quite sure most of you have read Cloherty. Then NRP 8th edition questions are asked. NNG updates I have already posted. Go through the video I have posted just 2 months back. Video you need to be thorough with. Then congenital infections are important. And when I say congenital infection, not only the typical congenital infection, but you also need to be thorough with the uh, perinatal infections like herpes simplex virus. We have a tendency to ignore herpes. Herpes is asked. The SEM disease, the disseminated disease, and the meningoencephalitis part. Then oncologic emergencies is one of the favorite of examiners of super specialty exam, both NEET SS and INISS. Neuroblastoma, Wilms tumor, LCH, and germ cell tumor. Germ cell tumor, again, an area people have a tendency to read it, but you don't revise it thinking it is not important. Germ cell tumors are asked in the exam. And sickle cell anemia crises are important and how to manage them and how to differentiate them. What is the therapy in each variety? Hemophilias are important. Types of von Willebrand disease, type 1, 2A, 2B, pseudo, then paroxysmal nocturnal hemoglobinuria also needs to be done in these patients. So PNH is also needed in these patients. The PNH is also needed for these. If you have a fair idea, vaccines, obviously you will be going through some of the vaccine updates The important one-liners I'm going to discuss. National immunization schedule. I'm quite sure you all know and you all have gone through it already. So national immunization schedule is your responsibility. Points, additional points about vaccine exam, INICT exam in the recent years, topics which have been asked in the various review articles, and the changes which have happened. I'm going to summarize here. In the next 10 minutes, I'm going to summarize all of them together. So let us start with the vaccines part. The first thing we are going to discuss are the updates. There are two important updates on vaccines. Two important updates on the vaccines which occurred in the year 2023 in the national immunization schedule. So in the national immunization schedule, there are two important updates. The first update is that third dose of fractional IPV. Dr. Cypher is saying, sir, scabies and molluscum short update. Uh, Dear, the time that we have here is quite short, but let me plan something. If nothing else, I will put up a 10-minute update and post it by tomorrow in the PrepLadder YouTube channel. Okay. It will not be a live session because, again, I will have to summarize all the key points and summarize them at one place. But that's my promise. It will not be a live session. But tomorrow morning, I will record a small segment. Even if my face is not visible, I will put it up. I will share with the team. The video quality can be patchy because I'm traveling right now. Immediately after this thing, I am traveling, but I will make sure that you all get that. बाकी के टॉपिक्स इज योर रिस्पॉन्सिबिलिटी ओके दैट मच आई कैन प्रॉमिस सो थर्ड डोज ऑफ फ्रैक्शनल आईपीवी aquathortum which IPV vaccine prevent genital warts. It is generally the nonavalent one which is the best, but the Gardasil one also has protective efficacy against the strains which are producing, right? So third dose of, let us come to the topic. Third dose of fractional IPV was introduced at 9 to 12 months of age. Previously, we were giving only two doses as 6 weeks and 14 weeks, but now the third dose has been introduced. Remember, it is not a booster, it is a proper dose. It is a proper third dose which has been introduced. Second update which happened earlier, we were using, you know, that Japanese encephalitis vaccine, two doses are recommended as a part of national immunization schedule in endemic areas. What has happened now is earlier we were using the live attenuated form, the live attenuated vaccine, which was made in China. So origin of this vaccine was in China. The problem was availability. Problem was live attenuated means you need to reconstitute, and this was not included in open vial policy, and the cost was very high. Now we have introduced the vaccine called as Genvac vaccine. Genvac vaccine, which is the brand name, you should be remembering that this is a inactivated vaccine. It is a inactivated vero cell culture vaccine, also called as Kolar strain vaccine. Kolar strain vaccine, also called as 82156XY vaccine. This has replaced, this is an indigenous vaccine which has been developed in India and has replaced the older live attenuated vaccine. What it basically means is, what this basically means is that now you need to include, this vaccine is now included in the open vial policy. This has been now included in the open vial policy, and you can use multi-dose vial vaccines in the national program. And so this has made a huge change. Remember, the new vaccine is inactivated vero cell culture. What is the strain? Kolar strain. Kolar is a place in Karnataka. If you have watched that movie KGF 1 and 2, that is Kolar Goldfield. So KGF, Kolar place, not only gave us KGF the movie and Rocky Bhai and that, what was that music in the movie, background music? Na na re ra re na 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 re. Many people kept it as their ringtone also. It also gave us the strain using which we have created our own vaccine. And this is a major change. It is also known as 82156XY vaccine, right? So where is this vaccine given? Let us write down some points related to this newer vaccine, because examiner can ask you the details of this vaccine. So this is a vaccine which is given 0.5 ml intramuscularly, but only given in endemic areas. And what is the side where you will be giving? It is generally given in anterolateral thigh. The site will be anterolateral thigh. If it is an older child, for catch up, you can consider upper arm also. You can consider upper arm also. What is the dose regime? We give the first dose is given at 9 to 12 months of age, and the regime is two dose regime, which are given at least equal to or more than 4 weeks apart. So what we basically do is the first dose is given at 9 to 12 months. The second dose is given between 15 to 18 months when the patient comes for DPT booster. So two doses can, if you have missed the first dose, or if there is a catch-up vaccine, two doses beyond 1 year of age can be given up to at least 4 weeks or more than 4 weeks apart. And there is no booster which is needed in these patients. No booster is needed. No booster is needed. And this vaccine is absolutely safe. No serious side effects. No serious side effects have been found. No serious side effects have been found. Right? So this is the vaccine, and the key points, the two updates that you need to remember regarding the vaccine. Then there are some other updates, some other one-liners that you need to know. Then what are the types? Sometimes examiner puts questions on rotavirus vaccines available in India. So what are the various rotavirus vaccines available in India? First thing you need to know that there was a vaccine called as RotaShield. RotaShield vaccine was withdrawn because of association with high risk of intersusception. So which vaccine had maximum risk of developing intersusception? It was RotaShield vaccine, which was implicated. Then this other vaccine, so it was withdrawn. The second vaccine, which is now a part of the national immunization schedule, that is RotaVac. RotaVac is included in the national immunization schedule. What are the key points about RotaVac? RotaVac covers only one strain of rotavirus. So it is a single strain vaccine. It is a single strain vaccine, which is live attenuated. And what are the doses? 3 doses are needed, which are given at 6, 10, and 14 weeks. And the route is oral, and you will be giving 5 drops of the rotavirus vaccine. That is the dose that you will be giving. And contraindication to RotaVac includes past history of intersusception and any severe immunodeficiency, including HIV and primary infections, particularly those which affect the antibody as well as cellular. Regarding phagocytic disorders, the safety is unclear, but can be given in if the treating physician is comfortable about it. So this is regarding the contraindication. And remember that RotaVac vaccine for catch-up vaccination can be given up to 1 year of age. Sita Velan is asking, so sir, biostatistics need to be covered for NEET SS. Sita, generally the trend so far has been that biostats is either not asked in NEET SS or occasional question is asked. If more questions get asked, that will be surprising for everyone. Generally, biostats is more important for INISS. NEET SS, occasional question can be asked. So if you have not read before, you can opt, keeping in mind it's a risk, but you can opt not to look at it. Or you can just have a look. If you have prepared for INISS before, just have a look quickly about the major topics. So catch-up vaccination up to 1 year of age, which means if a patient who has not received comes to you after 1 year of age, you will not give RotaVac vaccine. So rotavirus vaccines are RotaShield, which was withdrawn. RotaVac is the one which is included in national immunization schedule. Then we have other vaccines like Rotatech, Rotarix, and Rotasil. And all of them are approved for use in India, but they are recommended only in the IAP schedule, that is in the private practice. But they are not included in the national immunization schedule. They are not used in the national immunization schedule. And also, you need to remember that out of them, it is the Rotasil which is found to be the costliest one. Obviously, examiner is not going to ask that particular point. So this is the second thing about the rotavirus vaccine. Third thing on which questions are being asked even in NEET PG exam. In the NEET PG exam, there was a question asked some years back, and it was repeated recently also. The question was that which is a vaccine which is not a part of national immunization schedule but needs to be given every year in high risk patients. And the answer was influenza vaccine. Now, you know the answer, but because NEET PG people are repeatedly asking, there is a possibility you may get similar thing in NEET SS also. So from a SS perspective, what are the key points about influenza vaccine? The key points about influenza vaccine you need to know. Now, influenza vaccine is a vaccine which is not a part of national immunization schedule, but it is given yearly in high risk individuals. It is given yearly in high risk individuals. So the question arises, what are the high risk groups? What are the high risk groups? I, national immunization, it is given yearly in high risk individuals as per IAP. You need to remember that it is not included in national immunization schedule. So according to Indian Academy of Pediatrics, you can remember like this, that according to Indian Academy of Pediatrics, I will write like this. According to IAP, influenza vaccine should be given in all children 6 months to 5 years, as well as children more than 5 years if high risk conditions are present. So what are the conditions in which high risk you consider and you give influenza vaccine? First of all, if the patient is having any chronic disease. Which chronic disease? If the patient is having any cardiac disease, like BSD or PDA or some complex heart disease or untreated ASD, or if the patient is having any chronic pulmonary disease like cystic fibrosis, or the patient is having any hematological disease like a anemia, like anemia. My battery is going. Oh, just a minute, please. Put it up on charger. Thank God, the charger was around only. Okay. So, cardiac, pulmonary, or hematological disease, these patients, hematological or renal disease, that is kidney disease or liver disease. So, any chronic illness, life threatening, serious chronic illness, you need to give influenza vaccine. Second, you will give in any patient who had asthma or wheezing episode in the past 1 year. Either it should be a diagnosed patient of asthma or any wheezing episode has happened in the past 1 year if it is documented. Thirdly, it should be given in other chronic conditions like sickle cell anemia. It should be given in diabetes mellitus. It should be given in SLE. It should be given in morbid obesity. It should be given in any patients with immunodeficiency. It should be given in patients with prolonged aspirin use due to any reason to prevent any viral co-infection and increasing the risk of Ray's syndrome. And it should be given in lab and healthcare workers who are exposed to infectious agents, which generally includes you and me. I take influenza vaccine And if you are not taking a yearly influenza vaccine, you are still not a complete pediatrician. Why am I saying so? See, taking vaccine does not decide you being a true pediatrician or not. What it basically shows is you are taking your health too lightly. At least 3 to 4 episodes of influenza in a year can be prevented, because kids tomorrow will be coughing on you, and you will not only be carrying the infection yourself, your working hours will be affected, but you will then be infecting your family members also. So because we the pediatricians have the one of among the highest exposure to influenza patients, it is very important that after your NEET SS is done, if you have not taken, the new vaccine strain is due to come anytime, generally gets released around April. So get a yearly influenza vaccine given to yourself, right? So this is regarding the IAP categories in which the patient needs to be given, high risk patients. So what are the key points about the inactive about the vaccine which is used? Now the influenza vaccine which is used in India, we don't use live attenuated vaccine. The only vaccine approved for use in India is killed vaccine or inactivated vaccine. And what type of vaccine we use? Inactivated quadrivalent vaccine is being used as of now. Trivalent vaccine not available. Live attenuated vaccine not available. So inactivated quadrivalent vaccine is the one which is being used. There are multiple brand names. You can use any of them. What are the key points about it? It should, what is the site where this vaccine should be given? It will be anterolateral thigh or upper arm, that is in the deltoid region. Dose will be 0.5 ml intramuscular injection. Intramuscular injection. When you give a first time vaccination in these patients, if the patient is between 6 months to 9-year old, we give 2 doses, at least equal to or more than 4 weeks apart. Then you shift to yearly dose. But if the first time vaccine is happening in you and me, I am already taken, so I will not come here. So if it is more than 9 years of age and first time vaccination, a single dose is generally good. And the timing of vaccine should be annual, ideally, ideally before rainy season starts. And when does the rainy season start? Depending upon which part of country you are staying, Kerala, it starts from June, and in certain parts, in the northern parts of the country, in Chandigarh and Delhi, it will be starting in August and September, August and July and August. And some parts of the South India, you will be getting, like Chennai and Hyderabad and other places, you will be getting in the winter season, the so-called winter season, that is October, November, December. And if you are living in Northeast India, the entire part is your rainy season. But ideally, it should be taken before the rainy season. So starting from April till June is the ideal time you should get this vaccine. So if you have not got it, you must get it done. So side effects are rare, but there is a 0.01% risk of developing Guillain-Barré syndrome. One thing I missed when I was telling you, Guillain-Barré syndrome, also called as Landry-Guillain-Barré syndrome, you have to do properly, because there was an outbreak of Guillain-Barré syndrome in Maharashtra, in Pune district, multiple places, and some cases were reported in Mumbai also. If your examiner is interested in knowing about Guillain-Barré, he or she may put a question. So Guillain-Barré syndrome, add that topic to the list that you are supposed to revise for your exam. And generally, we say that these patients should not be given in patients with egg allergy. But remember that the current inactivated vaccine we are using, it is not utilized on egg is not involved, and so egg allergies is no longer a contraindication. But for safety margin, for historical perspective, still we often ask about egg allergies. But inactivated vaccine, generally egg allergy is not of much significance, right? In the live attenuated ones, that is a concern. So this is regarding the influenza vaccine. Let us go to the next thing. Next thing we are going to take up, the next vaccine, are the status of the current malaria vaccine. Is a malaria vaccine available in India? The answer is no. Malaria vaccines not available in India. But that will not stop the examiner from asking you about it. Remember, it's a super specialty exam. So malaria vaccines, there are two types of approved vaccines globally, and they have been approved for use mainly for Plasmodium falciparum. So in endemic areas, these vaccines are approved by WHO. The first vaccine which was approved worldwide is called as RTS-S by AS01 vaccine. So RTS-S is the strain, AS01 oblique is the complete name of the vaccine. It is also known as Mosquirix. It is also known as Mosquirix. This was the first malaria vaccine which was introduced. There is a organization called as Bill and Melinda Gates Foundation which sponsored this vaccine, and this is currently used in the African world. So Mosquirix vaccine is a recombinant vaccine. It is a recombinant vaccine which consists of Plasmodium falciparum, CSP protein, against which antibodies are produced in the body. CSP stands for circumsporozoite protein. This is a protein which is seen in the pre-erythrocytic stage of the patient. So it is a vaccine which utilizes what is the antigen? Plasmodium falciparum, CSP protein. And the protective efficacy of this vaccine is not that great. It has been reported between 45 to 65% protective efficacy in the endemic areas. Then we have the second vaccine which was introduced. The second vaccine was introduced as late as 2023, 2024 in the endemic areas. And that vaccine is produced by the Serum Institute of India, right? You know Serum Institute, but it is not being used in India. So R21 oblique matrix M protein. This vaccine is used in India, and WHO is using this vaccine. This vaccine is also based upon the variant of the same protein, that is Plasmodium falciparum, CSP protein, but the adjuvants being used are different. And this vaccine has an efficacy of about 77% according to WHO website. So efficacy of 77% is seen in these patients. And both of these vaccines also, they use HBsAg proteins, while during formation of the vaccine. Again, details examiner is unlikely to ask you in the exam. Then what is the name of the dengue vaccine? Again, dengue vaccine is not approved for use in India. Dengue vaccine is not available in India, and there is a reason for this. I will come to this in some time. So dengue vaccine, the name of the globally recommended vaccine according to WHO is Dengvaxia. The name of the dengue vaccine is Dengvaxia. Now, Dengvaxia is a vaccine which utilizes it is licensed for use globally. This vaccine uses, it's a chimeric. It's called as a chimeric vaccine. This vaccine uses a yellow fever vaccine backbone with replacement of antigens, with the replacement of antigen derived from all four strains of the dengue virus. All four strains of the dengue virus. But it is found that protective efficacy is lowest. It has, if they ask you what is the protective efficacy of the vaccine, the protective efficacy is variable. WHO says it is between 25 to 59%, but it is lowest efficacy against type 2 strain. So type 2 dengue virus strain, it has the lowest efficacy which is found. Why it is not approved for use in a country like India is because in seronegative individuals, so somebody had never got dengue, in seronegative people, giving this vaccine, if they get dengue, the dengue tends to become more severe. The severity is increased in the patient. And so WHO says WHO says that it should be used. So WHO says it should be used in countries where dengue is so endemic, where most population is already seropositive. And so it will provide cross protection against the other forms of dengue vaccine. But if the patient is completely seronegative, it paradoxically can increase the risk of getting a more severe dengue vaccine, more severe dengue infection. And remember, what is the age group in which it has been approved for use in children? 9 to 16 years living in dengue endemic areas. There should be lab evidence of previous dengue infection, any serotype. So it should not be a seronegative individual. You have to check. And three doses will be needed in these patients given at 0, 6, and 12 months. 0, 6, and 12 months. So this is about dengue vaccine. So basically, I never had dengue, as far as I know. If I am seronegative, even if I live in a dengue endemic area, I am not eligible for this vaccine. But if you had dengue once and you are living in that area and 9 to 16 year and of course adults, then this vaccine is approved for use. Three doses will be given 0, 6, and 12 months. So this is regarding the dengue vaccine that needs to be given. Then catch-up vaccination scenarios are often asked in the exam. So super specialty, they can ask you some tough questions, some tough scenarios. So I'm giving the heading that vaccination scenarios. So I'm giving the heading vaccination scenarios. Vaccination scenarios. Now, any patient with previously unimmunized child comes to you. So I will write like this: previously unimmunized child comes to you. What should be the vaccination pattern that you should be giving? National Immunization Schedule and IAP differ a bit on this. National Immunization Schedule says that if age of the patient is more than 1 year, three vaccines cannot be used for catch-up, or they are not used for catch-up vaccination. And what are these three vaccines? One is BCG, second is pentavalent. You can use DPT, but pentavalent cannot be used, and third will be rotavirus. So these vaccines cannot be given. So if you get a case scenario where any of these vaccines is mentioned, you can rule out that option that this particular set of things cannot be given to the patient. Now, if the patient comes to you and you need to vaccinate, suppose, let us take a scenario, and there is a patient who comes to you, previously completely unimmunized comes to you, and patient comes to you at age equal to or less than 7 years. What is the vaccine schedule you are going to give? First visit, you will be giving OPV, you will be giving DPT. It can be either whole cellular or whole cell, or it can be acellular form, and you will be giving hepatitis B. Plus, BCG will be given only if age of the patient is less than 1 year. Then in the second, after 1 month, you will call the patient again and you will give OPV second dose. You will give DPT second dose after 1 month means about 4 weeks later, and you will give second dose of hepatitis B also. Then after 2 months, 2 months from the first visit, that is another 1 month later, you will be giving OPV third dose, and you will give MR vaccine. MR is measles and rubella, and you will consider giving typhoid. But typhoid is recommended in IAP, not in National Immunization Schedule. Not in National Immunization Schedule, right? And at 6 months, 6 months after the first visit, you will give DPT booster and you will give hepatitis B. DPT third dose, sorry, DPT not booster. You actually give it as a third dose. So DPT and hepatitis B. This will be the catch-up visit that you will give in a patient age less than 7 years. Add it somewhere, revise it 2 or 3 times. Then what about if the patient's age is equal to, if the patient is more than 7 years? In these patients, when the patient comes for first visit, you will be giving Tdap and hepatitis B vaccine. Unimmunized patient we are talking about. Second visit, that is 1 month later, 1 month later, 4 weeks later, you will give TD and you will give hepatitis B. And 2 months later, you will be giving MR vaccine as well as typhoid only in IUP, not in National Immunization Schedule. And at 6 months, you will be giving TD and hepatitis B. This is the vaccination schedule you are supposed to follow if the age of the patient is more than 7 years. Right? So these are some of the case scenarios, the key points about vaccination that you need to remember. Also, there is a phenomena called as vaccine memory. Case scenario can be asked to you if a DPT patient, if a patient got DPT vaccine at 6 weeks of age and did not get any other vaccine, now comes to you at 1 year of age. What would you do? You would give the second dose of DPT as if the gap has not happened. Right? You will not restart and you will not replace the vaccine. Right? Although we are giving Aqua Thotum is asking what if partially immunized like BCG and 1 or 2 doses of Penta, would that be counted? Then there are no guidelines for that. And for that, you will have to pick and choose. It needs to be individualized. If partially involved, again, there are no written guidelines. You need to go into the details, and unlikely if examiner will put question on this. Again, next thing. One more thing we missed out. What about the protective efficacy of BCG? Now, the funny thing, BCG was originally described and made for pulmonary TB, but the least efficacy of BCG is against pulmonary TB, right? That is the LOL moment for BCG. So protective efficacy ranges between 0 to 80%. Lowest efficacy between 0 to 10% is seen against pulmonary TB. However, BCG has better efficacy, more than 50% efficacy against the more severe forms of TB. That is, it is more efficacious against CNS tuberculosis. So tubercular meningitis and tuberculomas will not happen. Disseminated tuberculosis and also miliary tuberculosis. So these are the three forms of TB against which the protective efficacy of BCG is strong. Tanya Sood, if it is national immunization schedule does not recommend influenza in any catch-up vaccination. If you want to do give it, and if the patient fulfills any risk factor and it was missed, then you can definitely give it. But the condition needs to be fulfilled. Regarding Japanese encephalitis, again, endemic areas, you can give 2 doses 4 weeks apart. That was the schedule that I told, but only in endemic areas. Right? Otherwise, it is not included in the guidelines issued by under the National Immunization Schedule. The values, the things I discussed with you, these values, these timings and the vaccines are taken from two sources. One, OP Guide 10th edition, the new edition, and second, from the Ministry of Health and Family Welfare, MOHFW website. And apart from that, IAP points I added to it. Next thing, let us discuss a few words. Let us discuss a few words related to G6PD deficiency. Why am I taking this out of nowhere? G6PD deficiency, a few points are needed because there was a question asked in NEET Super Speciality 2023. There was a question of this. So let us do a rapid fire review of G6PD deficiency. First of all, what is the inheritance? I hope you all know that G6PD deficiency is quite common in a country like India. So X-linked recessive. So it will be seen in boys and girls will be carriers. It is more often seen in Mediterranean and Asian ancestry and northern parts of the country, including Punjab. G6PD deficiency is highly prevalent. Now, what is the clinical? We know that G6PD is an enzyme which is present in RBCs and it is responsible for counteracting and managing the oxidant damage. In G6PD deficiency, any oxidant stress can cause hemolysis of the RBC, leading to hemolytic anemia. Hemolytic anemia. Okay. So what is the clinical presentation? So clinical features, these patients present with intermittent, that is episodic hemolytic anemia. They present with intermittent or episodic hemolytic anemia. What are the factors which precipitate hemolysis in these patients? And this was the MCQ asked. Options could not be recalled. This was the question asked in one of the 2023 papers, as it was said. Now, options could not be recalled. So, factors for precipitating hemolysis in G6PD deficiency, it includes drugs like primaquine, the anti-malarial agent, nitrofurantoin, sulfonamides, including cotrimoxazole, writing in bracket cotrimoxazole, trimethoprim sulfamethoxazole combination, then nalidixic acid among fluoroquinolones, and then phenazopyridine. These are the drugs which can cause hemolysis in G6PD deficiency individual. Secondly, there are food items like fava beans. Fava beans are not commonly found in India, but they occur as a part of staple diet in Africa. They can cause it, and sometimes non-specific viral or bacterial infections can also produce it. Viral or bacteria can also produce it. Sudhindra Lakshman, special situation in vaccines are steroid usage and on chemotherapy. Sudhindra, I would say that for that, there are two tables I can recommend. If you can get hold of OPGAI latest edition, the 10th edition, there is a red colored text, red color cover of that is there. There is a table, very beautiful, newly added table given there in the chapter on vaccines. You can go through that. Apart from that, IAP vaccine update also has tables mentioning about when specific scenarios and what is the vaccine that you should be giving. Regarding steroid intake and vaccination, please go through vaccination in nephrotic syndrome. The ISPN guidelines talk clearly about it. And this is something which is relevant, and this is something you can add from that particular source. Because we have a very limited time and the exam is around the corner. So, and yes, if you need any other help apart from the updates and anything, please post it on the Telegram group. Even if I'm traveling, I will try to answer and post relevant updates with all of you, right? So factors precipitating hemolysis are these. Then what are the lab investigation findings that you will see? So when you investigate these patients on investigation, you will find two types of bodies or cells. You will find Heinz bodies. Heinz bodies appear as inclusions. They are inclusions found in RBCs due to denatured hemoglobin. So denatured hemoglobin appears as Heinz bodies. So oxidant stress causes denaturation of the hemoglobin, leading to Heinz bodies. And second is bite cells. Now, cells which have oxidant damage, when they pass through the splenic sinusoids, the splenic macrophages bite upon their surface, producing splenic, the part where inclusion bodies are present, that part is removed, forming the bite cells. So bite cells are produced when abnormal RBCs pass through the spleen. And obviously, investigation of choice will be measurement of G6PD levels. So G6PD level measurement is commercially available. And treatment is supportive. You avoid precipitating factors and you give early therapy for infections. That is the only therapy that is recommended in these patients. Samarpratim TCV booster is not recommended. TCV booster is not needed. If it was a typhoid conjugate vaccine, then the booster is no longer needed. The currently used vaccine, like for example, we use type bar TCV. Type bar TCV booster you don't need, but type bar original used to require a booster every 2 to 3 years, 2 to 5 years, right? So now booster is not needed in typhoid, provided the primary vaccination is complete. Then few words regarding the topic I was telling you about thalassemia. So a few words regarding thalassemia. What is thalassemia? Some of the things you already know, I will just talk about it. Thalassemia belongs to a group of disorders which are called as hemoglobinopathies. Now, the normal hemoglobin is a tetramer of 2 alpha and 2 beta chains. And these globin chains, if there is a defect, If there is a defect in the alpha chain, we get alpha thalassemia. If there is a defect in the beta chain, we get beta thalassemia. Generally, the more common variety and which is relevant is beta thalassemias. So remember that beta thalassemia gene, first of all, you need to remember that beta thalassemia gene is present on which chromosome? It is present on chromosome number 11, right? And what are the three types of chain production? There are multiple types of chain productions which can occur. In case the examiner uses the word beta, that stands for normal beta chain production. If they write beta plus, that means reduced production is seen. And if they write beta naught, that indicates absent beta chain production. That indicates absent beta chain production. And in this gene, what is the most common type? This is an past MCQ point, बहुत पुराना question है NEET SS 2018 का. What is the most common type of mutation producing thalassemia, beta thalassemia? It is point mutation, which is seen, also called as splicing error. So splicing error or point mutation, it is mentioned in Nelson also, which is the most common type of mutation. Aquathotum, if you have time, you can refer the purple book, but don't try to overdo it. Generally, 1 to 2 questions are asked from, and the book is quite big. So if you have not read it before, if you have read before, then it makes a difference. But if you have not read before, only do selected parts or the special scenarios. Don't try to overdo also. So this is regarding the initial segment. Now, beta thalassemia, depending upon the chain combination, you can have 3 subtypes. So 3 types of beta thalassemias are available. The first type of beta thalassemia is the beta thalassemia major. This is the transfusion dependent part, also called as Cooley's anemia, also called as Mediterranean anemia. These are the 2 alternative names of the same condition. This is homozygous variant. Homozygous means the patient will be beta naught. That is beta thalassemia major. This is the most severe form. This is the transfusion dependent form. And these patients have no beta globin chain production. These are the patients who are found to have severe transfusion dependent anemia. They are transfusion dependent anemia. And they are the ones who are having increased HbF. And they are the ones who are having hemolytic facies. The so-called chipmunk facies is seen predominantly in these patients. And they are the ones whose X-ray skull will also show crooked or hair on end appearance. The second category is beta thalassemia intermedia. Beta thalassemia intermedia. So they will be compound heterozygous and they will have a pattern called as beta naught, beta plus. So they are called as compound heterozygous. Compound heterozygous. And beta thalassemia is the form in which you will have hemolysis. So hemolytic anemia will be there, splenomegaly will be there, jaundice will be there, gallstones will be there, but it will not be transfusion dependent and they will present, the time of presentation in the patient will be beyond 2 years of age. Beta thalassemia major will present as soon as the first 6 to 7 months are over. And the third category is the beta thalassemia minor. This is the variety which is confused with iron deficiency anemia also. So the third variety is beta thalassemia minor, also called as beta thalassemia trait. Minor and trait are the same thing. They are not separate things. And these are the patients who are having, they are heterozygous with one of the multiple types of heterozygous forms are available. One of the chains will be normal beta chain. So there will be some degree of beta chain production happening. And these are the ones who are confused with, they resemble iron deficiency anemia. And these patients have elevated levels of HbA2 along with minor increase in HbF levels, right? So these are the 3 types of thalassemias that you need to remember. Now, what exactly happens in thalassemia? We need to understand that. So what basically happens is that there is decreased beta chain production with relatively increase, because beta chains are not getting produced, along with relatively excess of alpha chains. And this will lead to abnormal erythroblasts. So the primitive RBCs which are produced, they are called as erythroblast. They will be abnormal. Now, most of these abnormal erythroblast will die in the bone marrow by apoptosis. And this is why erythropoiesis is happening, but we call it as ineffective erythropoiesis. You must have heard the term ineffective erythropoiesis, but what is the meaning? These abnormal erythroblasts die before they become mature RBC. So that is called as ineffective erythropoiesis, which is considered to be the hallmark of beta thalassemia major. So if they ask you what is the hallmark of beta thalassemia major, it is ineffective erythropoiesis. At the same time, a few abnormal cells, some of them will enter the circulation. They will enter the circulation, but they will have reduced lifespan. The T half of these RBCs will be less because excess alpha chain will form aggregates. They will precipitate and form aggregates, damaging the RBC membrane. So they will be prone to develop extravascular hemolysis. And the site of extravascular hemolysis will predominantly be occurring in spleen. And because of extravascular hemolysis, these patients will develop hemolytic anemia. They will develop hemolytic anemia. Now, because of this ineffective erythropoiesis, again, patient is having anemia. Now, when there is anemia, there will be need for blood transfusion. So it is a transfusion dependent part. At the same time, these patients, due to anemia, the patient will develop tissue hypoxia also. When tissue hypoxia happens, it leads to erythropoietin release. So there will be more amount of erythropoietin getting produced. And increased erythropoietin will cause two things. It will cause extramedullary hematopoiesis. Extramedullary hematopoiesis. This is the one which is responsible for hepatosplenomegaly occurring in the patient. Hepatosplenomegaly. And secondly, increased erythropoietin will cause expansion of the bone marrow spaces, producing the hemolytic facies and skeletal deformities. And this, my dear friends, is the pathophysiology of why all these manifestations that you read tend to occur. I'm zooming out a bit. This is what is happening in a patient of thalassemia. So I hope you can understand it better. Since last many days, including on my Telegram group and including some of you who know me personally, you have messaged me, ki, sir, briefly summary bata do. Because yes, questions are asked on what exactly happens here. True statement, all of the following are true except, all of the following are false except. This thing is given in Nelson, but not in the way that, it is useful for your exam. So I have just summarized it in a way without overdoing it. So you can always see it later. And this is the one that you need to remember. It's very, very important for your exam, right? So moving further, what are the clinical features? Now they will have chipmunk facies, they will have anemia, they will have hepatosplenomegaly. Chipmunk facies will include. Now let's summarize. Let's summarize. Now that we are doing it, let's finish off the topic fast. So clinical features of beta thalassemia major. I'm talking about beta thalassemia major, right? So these patients will have anemia, they will have hepatosplenomegaly, they will have hemolytic facies, also called as chipmunk facies. What are the features of chipmunk facies? These patients will have facial dysmorphism in the form of frontal bossing, depressed nasal bridge, also called as flat nasal bridge. They will have maxillary prominence. So maxilla becomes prominent. They have a pinched nose. They have prominent incisors. Many times the incisor will be protruding forward, and they will have dental malocclusion. These are the manifestations which will occur in chipmunk facies. Apart from that, these patients will have recurrent fever as well as failure to thrive. This occur because of hypermetabolic state being produced due to ineffective erythropoiesis. So there is low level inflammation also which is happening at the cellular level in these patients, which leads to recurrent fever and failure to thrive happening in the patient, right? So these are the manifestations. Now, investigations, you already know, HB electrophoresis can be done, HPLC testing. Then you have the so-called target cells. X-ray skull will show the typical um, hair on end or crew cut appearance, and then there will be elevated HbF, slight elevation in HbA2, significant level of HbF, whereas HbA2 level will be suggestive of thalassemia trait in the patient. Now, it is the treatment part that we need to focus on. First of all, Nelson talks about how much therapy do we need. So, patients who require transfusion treatment, these patients will require uh, blood transfusion repeatedly, and the target for blood transfusion is HB 9.5 to 10.5 gram per deciliter. We call it as pre-transfusion level. So before the next transfusion happens, the pre-transfusion target level of HB should be 9.5 to 10.5 gram per deciliter. That should be the aim. Now, what are the therapies that we are going to do? Now, first of all, regular blood transfusion. When do you need? So first therapy is blood transfusion. It is started from 9 to 12 months of age. And when do you give it? It is given every 3 to 4 weekly. It is given every 3 to 4 weekly. And this is the target hemoglobin, which must be remembered in your exam. Some of the Indian textbooks give a range of 9 to 10 gram per deciliter, but Nelson 22nd edition says 9.5 to 10.5 gram per deciliter. First is blood transfusion, and it will be needed lifelong. Second is chelation therapy, because these patients have iron load, which is the major cause of cellular toxicity, and they can cause endocrine imbalance, including hypothyroidism and pubertal disorders as well. So chelation therapy, remember, uh, whenever you have to check iron stores, serum ferritin is not a good marker. It is not a good marker of tissue toxicity in the patient. So best marker in these patients is MRI. You can do the MRI of the liver and MRI of the heart. So MRI, particularly there are images, that is, in case of heart, we do T2 MRI, T2 images, and liver, we do R1 or R2 star images of MRI, which are done, which are the best marker, and they detect tissue iron stores better and earlier before the sign and symptoms of toxicity of these organs will appear. And when do you start chelation therapy? Chelation therapy, time to start. This is important. I'm putting a star. It should be started after 2 to 3 years of BT, that is blood transfusion initiation, or it should be started if the total serum ferritin value becomes more than 1000 microgram per liter, which is the same as more than 1000 nanograms per ml, or if the liver iron concentration, when you do quantitative measurement, is more than 5000 microgram of iron per gram dry weight. Per gram dry weight. This is the time. If any of these condition is fulfilled, you will start. If any of these condition is fulfilled, you will start chelation therapy in the patient. And so the question arises: what are the chelation agents which are approved for use? So what are the agents approved for use in these patients? First of all, we have the deferoxamine. Deferoxamine, it is written as DFO. Deferoxamine was the first agent which was approved, and it is parenteral. It is very effective, but requires to be given as subcutaneous infusion. And so the problem is that the patient needs to go to a daycare center to get that. Second is the oral agent called as oral deferiprone. Oral deferiprone is approved for use in these children. It is a relatively cheaper agent and widely used. But the problem with deferiprone is that they have a side effect of cartilage damage. They can damage the cartilage and they can cause neutropenia. So neutropenia is also written as agranulocytosis. That is the side effect. Third agent which has been approved for use in these patients is oral deferasirox. Oral deferasirox. Please ignore my bad writing. It's already more than 1 hour, but we will finish it off properly. So oral deferasirox is costlier, but is better tolerated. And this is one agent which is highly efficacious in removing both intracellular and extracellular iron stores. It can very effectively remove intracellular and extracellular iron stores. Extracellular iron stores. Then the side effects, it include nausea, vomiting, and some degree of hepatotoxicity or renal toxicity. So you need to follow LFT and RFTs in these patients repeatedly. And fourth, you have the curative, and these are the three agents. Then you have the curative therapy. So first was blood transfusion, second was chelation therapy. Then we talked about the three agents. What is the curative therapy in these patients? It is HSCT, that is bone marrow transplant. It is curative. And what is the new therapy? Now gene therapy is available. The gene therapy is called as beta-biglogene autotem cell. There are new therapies which have been approved. If you are running short on time, please go through the update I have posted in Nelson updates in the app super specialty part. I have posted that update. So new gene therapy which is approved for use, it is beta-biglogene autotem cell, also called as Betty cell therapy. Called as Betty cell therapy. Betty cell therapy. And beta-biglogene is approved for use in the age group of 5 to 50 years. And these patients, we use CD30 positive hematopoietic stem cells, where lentiviral vector is used to insert the corrected gene, and then these cells replace the autologous bone marrow by infusion into the patient. So this is highly efficacious. And what is the criteria for beta-biglogene stem cell? It should be given to individual who require equal to or more than 8 to 10 blood transfusion per year, or there is a need for 200 to 250 ml per kg of packed red blood cell transfusion per year. These are the patients who are candidates for beta-biglogene autotem cell. And also remember that if already cellular toxicity has set in due to iron toxicity, then this therapy is not indicated. So appropriate use of chelation agent is a must before this therapy becomes widely available, right? Priya is asking about a question. Priya, HBE, beta thalassemia, HPLC chromatography question was asked. Can you explain? Priya, without knowing the question, it is very difficult for me to comment. Once this video goes up, you can put up the question, whatever fragment you can find, and I will try to answer in the comments, right? So, dear friends, what you asked from me, I have just posted it here, and we are done with the time also. Before I go, as I said, my promise, scabies molluscum, what Nelson says, key points, short 5 minute summary. Watch out for it on the PrepLadder YouTube channel shortly. Tomorrow is Sunday, so I don't think they will be working. So I will record it tomorrow, and Monday I'll make sure it comes up on the YouTube channel, right? Not on the app. It takes longer time there. So I will share it with them. So you can add it to the notes. And in case you want anything specific, once this video goes up, the recorded part, you can post the comments. And I will try my best to remain active till the exam and try to answer your queries. So I know it's a very, very brief video which I have done, but you all wanted me to discuss. I have taken out segments from Nelson and just given what you all might need before you sit in the exam. Eventually, there is obviously no replacement, and it's a last resort revision, right? So thank you so much, and all the best. Keep working hard. We'll be in touch, and watch out for that infection-related one-liner video on Monday. I'll give it to them tomorrow, but it will be posted on Monday, right? Thank you so much. All the best, and God bless you.